Hello, everyone. We will start this webinar about Vinramoov. So I am Nicolas Plumier from Techno, and you are all welcome to this live webinar about Vinramoov technology and its innovative technique, functional proprioceptive stimulation in neurorehabilitation. I think we have around 45 to 50 people joining us at the moment. This will increase step by step. We are waiting for the people coming. And I would like to thank you all for being here and coming from all over the world. First of all, before starting, just some technical points, practical informations. All the microphones have been turned off, and if you have questions during the presentations, please use the dedicated question and answer sections on the bottom of the screen. We will try to reply all of them at the end of the session, or at least individually later on by email. So this session will last around 1 hour. And the first 30 minutes will talk about Vinramoov scientific background and physiological principle reminder. Also, you will see the large panel of clinical applications of Vinramoov, one of children case report video, and we have the pleasure today to welcome 3 speakers, and the 30 last minutes will be split in 3 parts with 3 different speakers presenting 3 ongoing clinical research projects using Vinramoov and focused on the early treatment with functional proprioceptive stimulation. So let's go on with the presentation. Just a short introduction about the 3 speakers coming at the second half of the session. Professor Bernard Viguet from the University Hospital of Kremlin-Bicêtre in Paris, France. He is member of the French Society of Anesthesia and Intensive Care Medicine. He is president of the Association of Neuroanesthesiology and Critical Care. His topic today is about spinal cord injury, and the goal of the research project is to bring evidence of the need of a very early oriented rehabilitation with FPS, with Vinramoov. It's a multicentric, placebo-controlled double-blind study. The second speaker today, we have the pleasure to welcome Maud Pradine from Créteil, close to Paris in France. She's lecturer, researcher, and physical therapist, expert in neurophysiopathology, especially on spastic paralysis. And the topic today of her talk will be about the study she's running about stroke and to prevent muscle disorders and agonist paralysis through early focal vibration with Vinramoov. The third speaker is Renaud Marquis from Lausanne in Switzerland, from the University Hospital. He is a research officer and neuroscientist expert in brain medical imaging, programming and data acquisition and analysis. The topic of his lecture today will be about his research on coma and disorder of consciousness patients, showing the interest of using functional proprioceptive stimulation as an early diagnostic marker in patients with this DOC syndrome. Let's go through the presentation and the physiological principle of Vinramoov. So first of all, Vinramoov is a unique solution in neurorehabilitation. It's a new technique, a new way of stimulating the patient, and especially post-stroke patients, traumatic brain injury, spinal cord injury, coma, cerebral palsy, etc. All the neurological conditions you may know. And Vinramoov technology is based on 2 main modes. And you have to know that each of these modes are, each mode is really using a very specific physiological principle of action. The first one, mode 1, FPS, is triggering sensory motor functions. The mode 2 focal vibration is used for muscle tone regulation through the stimulation, especially of spastic patients. So let's go with the first mode, which is the main one and the more advanced and the more innovative differentiating Vinramoov technology from others. FPS, of course, in this word, you have the P for proprioception, which is really the basis of the action of this technique. So just as a reminder about muscular proprioception, when you are performing a movement, like here on this picture, an extension movement of the elbow, one muscle is in charge of the motor function, here in red on the left part of the screen. And here it is the triceps. He's being contracted. This is the agonist word, who is receiving the order to be contracted by the central nervous system. At the same time, during these movements, you have the antagonist muscle, here the biceps, which is being stretched during this movement, and is in charge of the sensory motor, the sensory function, to give back the movement feedback to the central nervous system. And the sensor in charge of that is especially the muscle spindle, and this is the entry point of Vinramoov stimulation technique. The sensory motor, the sensory function of the muscle through the muscle spindle is coding the position and the velocity of the movement. On the picture on the right, you can see a contracted muscle. You can see the right picture showing in yellow a very slow frequency activation of the 1A afferent fibers during a muscle contraction. But when the muscle is stretched, the muscle spindle is sending back to the brain a high frequency of activation to the brain in order to code and describe the movement characteristics during the movement. So this muscle spindle linked to the 1A afferent fibers is the entry point of FPS technique with Vinramoov, and it's coming from something like 15 years of research, partnership with the neuroscience lab in Marseille, especially with the professor Jean-Pierre Roll. And they were using a technique called microneurography to understand how was described the information received by the brain to describe the movements and especially recording the unitary afferent signal on the 1A fibers by inserting a tungsten microelectrode in the peripheral nerve. So here on the video, you will see how was used this technique. It's a laboratory technique. Here you can see the muscle spindle linked to the 1A afferent fibers during contraction, no activation, and activated during stretching. Here you can see the experimental microneurography with this microelectrode being inserted into a peripheral nerve to record the movements, characteristics, and the action potentials on the 1A fibers, especially. During the movement was performed by a robot-assisted technology, describing 3D complex movements like drawing a shape or drawing a letter, like a hem here with the ankle. And during this passive movement, we can record the neurosensorial barcode, coding very accurately each movement in all the direction of the joints. This is the knowledge that allows us to know where and how he's described the proprioception signal. And this is what is used in the FPS technology to pilot our stimulation. So here you can see a message on 1A afferent signal on the biceps during an extension movement when the biceps is being stretched. This is what goes back to the brain during a normal movement, a real movement. So here on the screen, you can see that there is two peak, meaning two maximum extension of the biceps. If we are able, and we are able to do that with FPS stimulators, we are copying exactly one-to-one the action potentials of the normal natural signals going back to the brain during the movement. If we are copying that into mechanical stimulation, vibration basically, but frequency modulated, during no movement, if the person is not moving during the stimulation, we can record with microneurography exactly the identical information going back to the brain, even if the person or the patient didn't move. So it's a trick going back to the brain. It's an illusion of movement, a neurosensory trick. And you can feel identically the same sensation as a normal movement, like an extension movement of your elbow. It means the brain cannot know if this information is coming from a normal movement or from the stimulation. Here, this is quite the same picture, but step by step. If you look step 1, FPS stimulation, it's placed on the myotendinous junction in order to activate inside the muscle spindle. Then step 3, the proprioceptive message is going through the 1A fibers, identical to a muscle lengthening, like if you were, for example, stretching the biceps. And the brain, step 4, the central nervous system is activated, the sensory motor areas are activated, identically as a normal movement, and you feel an illusion of an extension movement. So it means in blue, we are through the proprioception activating the same pathway as a normal movement for proprioception, but the movement was not performed. But what is more important is the red on the right, the reaction of that, the motor reaction. It means that the brain received the proprioceptive signal of a movement that was not performed, and in reaction to that, we call that motor response. The brain will order a muscle activation of the antagonist muscle in order to initiate the movement in the same direction of the illusion of movement received. So by stimulating the loop from proprioceptive information to motor reaction, Vinramoov is really able to activate the full sensory motor loop. And the most important is that the brain is involved in this loop. The motor reaction is not provoked by an external stimulation. We provoke a sensory input that pushes a motor reaction. This is a study we ran in partnership with the lab in Marseille in 2012 to show if the functional proprioceptive stimulation are able to limit the side effects of immobilization. So it's not patients, it's normal subjects, healthy people. They were blocked into a cast during 5 days from the wrist to the top of the fingers. And before placing this cast, they measured the functional MRI activity and the range of motion of the wrist movement. There were two groups. The first one had just a conventional immobilization, and the second one received at the same time as the cast. They received stimulations. You can see the blue, red, and the green dots showing the place of stimulators activating movement of flexion or extension of the wrist and abduction or adduction. They received that twice a day for 30 minutes. So here you can see, maybe it's a bit small, but I will be quick on that. It's huge results on the fMRI recordings. On the left, you have the people who didn't receive the stimulation, and on the right, the one who received the stimulation. On the first line, you have one person before and after the immobilization, and for each of them, we can see a significant, huge decrease of two things. The first one is the size of the activated area corresponding to the wrist movement, but not only the size, but also the intensity of this activation was drastically reduced. You can see that through the color. The more it is white, the more it is intense. On the contrary, on the right side, you have all the patients treated with the stimulations, and you can see for all of them an exact identical and no more significant difference between the areas activated and the intensity. It means these people, even if they were not able to move because the cast was blocking them, the brain activity was kept at the exact identical level. The second measurement of this study was the range of motion, and we can see also big results. You can see on the left, without FPS, there is a huge decrease for all the degrees of freedom, abduction, adduction, flexion, extension of the wrist, which is highly significant before and after removing the cast due to the immobilization. On the right, with the functional proprioceptive stimulation, you can see that there is still a small decrease, but which is no more significant. And for all the range of motion, all the degree of freedom of the wrist. So it means even if these patients, these people, were not able to move, there is a result on the real range of motion capacity when removing the cast. So just as a summary, FPS are mechanical stimulations. It's not an electrical stimulation. It's a frequency modulated vibration from 40 to 100 Hertz, and it's applied on the myotendinous junction. It's non-invasive. It's copying the 1A afferent patterns on the 1A fibers. The FPS are able to induce sensation of real movement and activating the CNS like a real movement. And the second step we talk about is that the FPS is also able to trigger a motor response matching with the elicited sensation. And the last point, it's important that you realize that this is not a reflex, it is a central nervous system loop and not a spinal protection reflex. And maybe this is something about opposite to this reflex. Here you will see the different protocols of Vinramoov application into the neurorehabilitation continuum. So Vinramoov is made to follow up the patient's progress during the sessions. So here you have a patient just after the ICU in the bedridden position for lower limb stimulation. The legs just need to be suspended, and the 12-channel stimulators piloted by the control station are synchronized in order to provide functional 3D real movements involving all the joints from ankle, knee, and hip, for both legs at the same time. Then the second step, as soon as the patient can be verticalized, we provide also a specific standard in which the patient can be in open chain for gait-like patterns. Then this step is an example with a spinal cord injury patient, synchronized with a treadmill for walk patterns with a harness for security, of course, and the FPS stimulation is synchronized during the walk of the patient. The next one you will see is a free walk. First the balance training first. This is an important mode that allows the patient to train the balance. You can see at the same time the setup of the stimulators. Each stimulator is placed with a specific orthosis for each joint. Here, this is an amputee patient on the right leg below the knee. And the goal was to train his balance with this brand new prosthetic leg to prevent falls. Of course, this could be the same training for a stroke patient with hemiparetic patients or other kind of conditions. So it allows also to synchronize hip and trunk rotations, like you could see. Now we are on the more advanced stage where the patient is able to walk by himself, maybe between parallel bars for security reasons, but the synchronization of the stimulations allow a smoother overground gait. And here, the same patient with the amputee leg is walking completely freely on the ground, with the stimulation pushing him to have the right rhythm during the gait. Now for the upper limb, the same stimulators can be applied for upper limb treatment. This is an example of stroke patient with the right hemiparetic arm. And the control station, you can see he's showing a picture of 3D movements for catching tools to perform fine control movements with 8 channels stimulation on the shoulder, on the elbow, on the wrist, and also they could be applied on the fingers. This is an example of activity of daily living, like taking and drinking a glass of water. So here the patient is asked to perform the movement also at the same time with an active control. So just to sum up the 3 steps of the protocols we are using with Vinramoov. With one patient, we are always trying to respect these 3 phases. The first step is first through the proprioceptive stimulation to initiate a sensation of movement, activating the sensory areas of the brain like a normal movement. So in that phase, the patient is normally able to recognize the movement, and we try to have the feedback of the patient when he received this information and recognizing the movement. So it's a bottom-up input. The second step is to get motor responses. So here on the video, you can see that this patient is moving even if we are not asking this lady to move her legs. This is the normal reaction of the brain, a top-down reaction to the FPS. triggering a motor response. And the third step is to ask the patient to move by themselves at the same time. Basically, we say them that if they are able to feel the movements, they are able to recognize the movements, then we ask them to perform an active control. The second mode is focal vibration. So you have to understand clearly that this second mode is using a different physiological principle compared to the first one. And this mode is based on muscle tone regulation. So focal vibration is a stimulation applied on the middle of the muscle, no more on the musculo or myotendinous junction. It's really a more fixed frequency. There is no sensation of movement during this stimulation. And the goal is to increase the tonus of the muscle being stimulated. And the goal at the end is to control the tonus balance between agonist and antagonist muscles and reduce the level of muscular hypertonia. Basically, for a highly spastic patient, we are applying the stimulation on the antagonist muscle of the spastic. And the last point is that this mode is very, very important to reduce the spasticity for a couple of hours, sometimes days, and facilitating to perform the mode 1 for movement and sensory motor training. About duration and frequency. Of course, if we have to reply to the question when, the answer would be as early and often as possible. There is no limitation to use the functional proprioceptive stimulation, no contraindications, and allowing to use it in the very earliest stages. Also, there is no limit to use it several times per day, for example, but the recommendation is around 4 to 5 times a week. Of course, each day would be the best. And the duration of the sessions are different from the mode 1 and the mode 2. For the mode 1, we are around 10 minutes for the upper limb to 30 minutes for the lower limb. And the mode 2 for tonicity regulation is a more long session to have greater results, at least 30 minutes. And if you can, we can go to up to 1 hour. Intensity, I will not go too deeply into the details, but of course, Vinramoov allows to change the intensity level for the mode 1 and also for the mode 2, depending on the stage of the patient. And there is 128 protocols that allows to support the patient's progress all along the continuum of care. A short slide about ICU early treatment. Vinramoov is really something that is focused on the early care. The goal of this technique is really to be applied as early as possible. And sometimes we can see that between ICU and rehabilitation or early rehabilitation, there could be a controversy due to the fact that into the ICU sector of the hospitals, the people are, of course, taking care about respiratory assistance, and there is a restricted exposition to physiotherapy. At the same time, we know that we need to do things, mobilization or rehabilitation as soon as possible, repeating tasks with a high intensity and increasing step-by-step the difficulty. And we know that it's allowing better recovery. But we think that with Vinramoov and with the technique FPS, which is completely safe, it's really allowing to use it in the acute phase, directly in the bed, without having to transfer the patient from the bed to another system, and provoking early repeated action on neuroplasticity couple of days after a stroke or other condition. So it's also a way to prevent the sensorimotor deprivation due to the immobility in the first weeks and sometimes months in the acute care. As a summary, you can see that Vinramoov can fit in the different stages of the rehabilitation continuum, from the acute, subacute, and the chronic care. Of course, all of that is not addressing the same facilities, from in ICU to rehabilitation centers and outpatient clinics. And of course, in Vinramoov, you can select different protocols, and this device is mobile in order to be featured in the different tips or different type of facilities. Vinramoov is a complementary solution with other therapeutic tools. We are absolutely not fighting with robotic systems, with electrical stimulation. You have to understand this slide like a real complementary tool with others, but allowing at the same time to treat lower limb, upper limb in all phases for all conditions. Means Vinramoov is not certified only for stroke or spinal cord injuries. You can involve all these type of patients with that technique. The setup time is reduced to less than 10 minutes, even less than 5 minutes for the upper limb. The patient comfort and acceptance is very high. This is really comfortable and highly appreciated by the patients. And this is one of the only way to trigger motor skills directly from a brain reaction. Really, the goal is to involve the brain in the loop. And this is really what makes FPAs innovative and different from other techniques. So just to talk again about the different clinical applications, the main ones, of course, are stroke, spinal cord injuries, brain injuries, cerebral palsy, polytraumas, sclerosis, Parkinson's disease, and also, and you will see that in the last lecture presentation, that we can use it also on coma patients or with disorder of consciousness. To summarize also the clinical benefits, the main goals are to preserve the sensorimotor interaction, to stimulate the neuroplasticity, of course, to prevent the side effects of the immobility, especially in the acute phase, to enhance the coordination, promote the motor recovery, allow locomotor training, and this is more, the last one is more dedicated to the mode 2, focal vibration, to regulate the muscular activity. Here is the video to finish with my product presentation, and before welcoming our lecturers, video of children treatment case report. Let's start it. Rafael is a Pura syndrome patient. And you can see here on the video his motor function before the session she received in a French neurorehabilitation facility. And after several weeks of treatment with Vinramoov, she get a huge improvement in the walking conditions, from 5 meters to 200 meters per second. This is a fantastic result we wanted to share with you. Of course, this is a case report, and I will let the place now to more science with the 3 lecturers. And we are very, very pleased to welcome first Mr. Bernard Viguet, who is here with us and who will present his work in the Kremlin-Bicêtre, close to Paris hospital, the Tetramove project.
Hello, everybody. I will present you the protocol we are going to make, I hope. We need some administrative authorization, but we hope we have it in this week. So my name is Bernard Viguet. I am an intensivist in Bicêtre, Kremlin-Bicêtre. It's a university hospital, and I work in the ECU with Aurore Rodriguez, who is also intensivist, and with Anne-Claire Decruy, with physical medicine. So we have integrated one physical medicine doctor in the intensive care for our patient. And we have also a secondary post-intensive care rehabilitation unit, where Anne-Claire is the chief of this unit. So next slide. So that's what we want to do, and to make very fast, to begin very fast the rehabilitation of patient. And we have chosen the medullary patient, traumatic medullary patient. In our intensive care unit, we make a lot of traumatic patient. So we have a lot of traumatic medullary traumatic patient. So we begin very early and just after the surgery. And after we begin, we have the post-intensive care unit to continue. And after we have all the units of rehabilitation where we work with is in Garches, in Percy, with the military hospital, and with Neufmoutier. So you have all the team and doctors and kinesiotherapy. So the inclusion criteria was adults with high-level paraplegia or tetraplegia, and we don't take head trauma to distinguish the problems. In the randomization we are going to do is we are going to distinguish between complete or incomplete lesion. It's very important to follow the groups. And we begin on post-surgery. We made the surgery in the first day, every time. So 2 or 3 days after, most of the time, we're able to begin the protocol. So we start to 3 to 1 week after the accident. So we are able to start in the ECU because of our organization and the help of Anne-Claire Decruy. So after evidently receiving a patient agreement and the randomization as I tell you before. So next slide. So the first thing, say we are going to do the usual treatments, and we have made, we are expert on the last version of the guidelines, the French guideline, French recommendation for the management of patients with spinal cord. As you see, intensivists are in yellow, but we have introduced the presence of the physical medicine doctor in blue to help us to integrate the rehabilitation inside the ECU. So that the minimal basal things with the rehabilitation and passive mobilization of joints, positions of joint, application of the orthos, and manual muscular reinforcement. So next slide. Now for the protocol. Donc everybody had the usual treatment I just speak about. We have the intervention about 3 to 5 times each week, and we have 2 groups. We make a placebo group. We randomize patient, and we in the placebo stimulation. We do all things like the others, but the stimulation was very weak. So it's placebo stimulation or real stimulation, functional proprioceptive stimulation. We have measured the number of patients, and we are supposed to need 30 patients in each group, so 60 patients in the total. So we have the notion that we need 2 years to have all the patients. And we make the intervention 8 weeks in the UCU, in post-ICU, and in the rehabilitation centers I present to you. Next slide. So what we are going to measure, the first we have to choose a primary outcome, and the primary outcome, we decide to choose the spasticity, all kind of spasticity, and we try to follow the spasticity at the ECU discharge at 3 months and 1 year. 1 year was the head, the principal judgment. And we have secondary outcome. That's the primary outcome. That's we choose that because of simplicity. And for the secondary outcome, we are going to measure the same 3 months of our post-ICU, 3 months and 1 year. Pain, evidently. Verticalization, the after stimulation, what is it more easy to make verticalization, and the cognition also very interesting. So all the tests of cognition with a neuropsychologist we have in the team. So next slide. To finish to present in conclusion. It's very interesting to begin very early intervention, and the thing very important is the continuous chain, not interrupt the chain of rehabilitation. So we are able with the organization to do that. That's a multicentric placebo-controlled group, double-blind study. 3 years, we need 2 years for the inclusion and 1 year to follow up. And it's 1 year the principal goal. Very early intervention, starting in the ICU from 3 days, if it's possible. And post-ICU, I told you already. And we try with the team to have meeting every 4 months to know how we are and how the protocol goes. Well, thank you for attention. Finish. I'm sorry, I apologize for my English.
Thank you very much, Mr. Viguier, for the presentation. It was a pleasure to welcome you here. I would like now to give the floor to Maud Pradine from Créteil in France. She is a lecturer, researcher at the UPEC University and expert in neurophysiopathology. She will talk to you about stroke and treatment of spastic paralysis with FPS. Thank you, Maud.
Thank you very much, Nicolas, for offering the opportunity to present the work of our team about focal vibrations and the relative preservation of muscle health after a stroke. So I'm a physiotherapist and I'm working in the team of Jean-Michel Graciès, and we are working on different neurophysiopathological models, and I will speak to you more about spastic paralysis today. So yeah, thank you. Just to complete what you have just said, Nicolas, I would like briefly to go back through the pathophysiology of spastic paralysis. So yes, let me just explain what the natural history that has been described and published by Jean-Michel Graciès in 2005. So just after the lesion, the first symptom that appears is the paralysis. So which will lead to an imbalance between agonists and antagonists around each joint. So that the less paralytic muscles will stay in a shortened position. So in this context of paresis, the patient is often left hypomobilized during hours and days at hospital, and that has been said earlier, of course. So from the first hours already, the muscle shortening process begins, more in the antagonist muscles. So with a decrease of the longitudinal tension, and that will trigger a cascade of transformation in the muscles: genetic, molecular, histological, morphometric, biomechanical, and neurophysiological effects or transformation of this muscle. So next, the disuse, will also have a peripheral effect, and it will worsen the shortening. And on the other side, it will also have a central effect, leading to an increase of the paresis in the agonist muscles, this time through cortical, supraspinal rearrangements of the central nervous system. So then, yes, at the subacute stage, as you can see, will appear a third factor that hinder motor function. This is muscle overactivity. So it involves different types, among which spasticity, of course, but not only. We have also spastic dystonia and spastic contraction. And from then on, we will have a vicious cycle, shortening, overactivity, shortening. Next. And this vicious cycle will take place at the subacute stage, but will last for years, worsening over time this muscle disorder. Next, this is why, yes, we call this specific disease spastic myopathy. So from now on, you do understand why this true muscle disease, this pathologic entity, starting from the very beginning, needs specific treatment after stroke. So first of all, from the literature, we could not find any studies speaking about the treatment of muscle disorder after stroke at an early stage. So as a consequence, the question addresses in our study is whether muscle vibrations applied on antagonists muscles would be able to prevent, I don't know if you can activate this video on the right of the screen, but there is, you see, through vibrations, this repetition, large repetitions of minimal stretches. And one study of Guang et al. Evaluated the quantity of stretch during each oscillatory cycle, observing the wave of vibration through a high-speed camera. And the amplitude of stretch is, of course, less than a static stretch of high load, which would be necessary, but we could assume that this repeated micro stretch will be able to mobilize sufficiently the muscle to prevent, at least partially, the muscle disorder after stroke. So yeah, and the second objective of this this study, beside this muscle disorder, we would like to quantify in a third group the capacity at this stage to strengthen the agonist muscles through vibrations, as we have seen the effect of disuse and the benefits in healthy subjects, as explained by Nicola earlier, through the study of Rowley et al. In 2012 in healthy subjects. Yeah. Explaining the benefits of vibration. So as a consequence, we will, in this randomized control trial, select 3 groups 10 days after stroke for treatment of 3 to 5 times a week. And in the first group, the agonist muscles, and the third group will be dedicated to a placebo group. So in this group, we will have only vibrations at a low, very low frequency, a frequency insufficient to produce any significant effects. And beside these 3 groups, we will have a conventional therapy that will be equal, as this is a monocentric study. So the same treatment, physical treatment everywhere for every patient. Yeah. We will follow. So yeah, the main outcome measure will be a composite score, XA. So what is XA? It represents the capacity to perform active movements against the evaluated muscles, so against the antagonist. And it will be compared to a controlled composite that consists of untreated antagonists, of course. So the secondary outcome measures will be both clinical and biomechanical. So for the clinical evaluation, we have the 5-step assessment scale. So this is a specific scale that we use in our department of neurorehabilitation, and it quantified for each step precisely, degree by degree, the different disorders. So the passive disorder of the muscles, so through XV1, the extensibility, spasticity through, as Tardio scale, the XV3, angle of stretch, and stretch reflex, and the XA, as we mentioned earlier, that represent the combination between co-contraction and agonist paresis. And we will also, beside this functional also scale containing but it will depend on the capacity of patients, but a walking test on 10 meters, if possible, we will try to, and a score of quality of life. For the biomechanical evaluation now, we will quantify the stiffness from the muscle belly and from the tendon, as we know that we have specific modification of this complex muscle tendon complex, and we will also explore the parameter, the architecture of the muscles. So the fascicle length, first of all, as we want to fight against the shortening, but also the thickness, and yeah, in order to see if the atrophy is prevented. So thank you very much. Now we're going just to have an idea of the plan. We are going through the ethics committee allowance and then the recruitment of patients. Thank you very much.
Thank you so much, Maud, for this presentation of your work, which is fascinating. Thank you. Now I would like to welcome the third lecturer, Renaud Marquis. Renaud Marquis is part of Lausanne University Hospital in Switzerland. He is a research officer, and he will talk to you about disorder of consciousness patients and being treated in the ICU in this hospital. Thank you, Renaud, for being here. I give you the word now.
Yes, can you hear me? Can you hear me?
Yes, Renaud, we can hear you, yes.
Yes, good. Thank you for the introduction. I'm a neuroscientist in the team of Karine Dizran. So the acute neurorehabilitation unit at Lausanne University Hospital. And I'm going to present you a study that we started recently using Vinramoov device and a pneumatic prototype that we use for an MRI study. On the next slide, I think it's basically the aim of the study. The topic is could we use functional proprioceptive stimulation as an early diagnostic marker in patients with disorder of consciousness? So maybe the next line will be more appropriate. On the left, you see Karine Disran with a patient, the whole team in the middle, and on the right you see the key concept that is very important for the neurorehabilitation unit. There are different fates for patients with traumatic brain injury after being in coma. Some of them will recover very slowly, will have pronounced disorders of consciousness, and some of them, on the contrary, will recover very quickly. So the team developed a clinical tool that helps to distinguish between these two patients at a very early stage. Because in principle, based on the coma recovery scale, these two patients would basically, you wouldn't be able to make the distinction between them before 20 days. But the motor behavioral tool, the MBT tool, that has been developed at CHUV allows to make the distinction very early between these two subgroups of patients, which means you can then adapt the treatment and improve the recovery of these patients. But behind this, there is to date very little knowledge, at least, about the underlying neurophysiology behind this different fates in the recovery. So that's why we decided to run a study. On the next slide, I think you have, yes, the protocol. So the protocol of the study, we include disorder of consciousness patients and cognitive motor dissociation patients. So these two types of patient that I mentioned before, these two subgroups that have a confirmed diagnosis. Then we, of course, exclude patients with premorbid history of or developmental psychiatric or neurological illness. And then based on a pilot study that was conducted before, we found that in healthy controls, there are correlates of functional proprioceptive stimulation in healthy controls, involving mainly parietal electrodes. So on the right, you see the number of significant channel and the median p-value for healthy control subjects, where there were, let's say, blocks of vibrations applied using Vinramoov. On the bottom, you see in the middle the stimulators number 5 and 4 were the ones that were used on the participants. And these blocks of 3 seconds of stimulations evoked a different EEG activity on the scalp, mainly on parietal electrodes. We see also that these EEG changes are mostly pronounced on a certain frequency bands. So on certain frequency bands. So namely in the mu band. So that's what you see on the bottom right picture. So between 1 and 2 seconds after the onset of the vibration, we see a change in frequency bands affecting these parietal electrodes. And based on these preliminary results, we decided to apply this on patients with traumatic brain injury. And so on the next slide, you see the protocol, I mean, pictures actually of the protocol for the two studies, the EEG study and the fMRI study. So For the EG study, we simply use the Vinramoov device. I think if you click on the slide, there will be a zoom where we see the patient with the scalp EG, the EG net. There are 128 electrodes, and you have then the amplifier and the PC that is connected to it with the Vinramoov station that sends trigger every time there is a vibration applied. Then we have a similar setup for the fMRI, except that in this case we cannot use the normal vibration device because it is not MRI compatible, but Techno Concept developed a prototype which allows to do the same kind of stimulation using using a pneumatic system. So you see the MRI room with the MRI control room. There is in the middle a bottle of compressed air. Then there are tubes going inside the MRI room. And then the vibrators are ceramic in ceramic material. And then this allows to perform a vibration during functional MRI acquisition. And so far we have recruited already some patients, 5 patients so far, and we are looking forward for the results. And I think that's it for me.
Thank you, Renaud. Thank you very much for presenting the research project in Lausanne. It's a pleasure and very innovative project, and we are also delighted to wait for the results.
Thank you.
Thank you, Renaud. So, thanks to all the 3 lecturers, we are now at the end of this webinar. Just a way to summarize the way we are thinking about this new technique, Vinramoov. A sentence coming from philosophy, from Confucius: it doesn't matter how slowly you go, as long as you do not stop. And we really think that this sentence is really well summarizing what is the way Vinramoov was designed for. Not stopping and starting from the very beginning, as soon as we can, with precise and CNS activation, pushing the neuroplasticity. We have reached the time of 1 hour. There was a couple of questions, but I'm sorry we will not be able to reply them right now, but of course we will collect them and reply individually to all of them by emails. We thank you all again for your presence here in this webinar. It was really a pleasure to have you here. Of course, if you have other questions about the product, about the technique, clinical questions, of course you can contact us with the details you can see here on the pictures. And more than that, if you want, of course, you can also visit us in the south of France in our headquarters. Thank you again, and wish you all the best in these times, and maybe next time for the next webinar. Thank you everyone, and goodbye. Have a nice day.